Hello, and welcome to our article review presentation on motor speech disturbances in cerebral palsy and the clinical implications of working with this population. We are your presenters, Colleen Prendergast,
Dr. Schwab, and Haley Curtis.
Our intentions of this video are to pull together the common themes of how cerebral palsy may impact the following speech subsystems: prosody, articulation, resonance, respiration, and phonation. During this presentation, we will present findings from the 3 journal articles we reviewed in preparation for this video and relate the findings back to the role of the speech-language pathologist in the assessment and treatment of the speech subsystems. We hope that you find this presentation informative and enlightening. The first speech subsystem that we will be presenting on is prosody. I am presenting on the research reported in the review, Methods of Speech Therapy Treatment for Stable Dysarthria, by Rebecca Palmer and Pamela Enderby. The following treatment studies focus on reduction of rate of speech as a feature of prosody with the treatment aim of improving intelligibility. In their article, Hunter, Pring, and Martin compared strategies for slowing speech rate of dysarthric speakers with CP. Listeners were divided into 4 conditions and asked to write down the key words of a sentence. The groups were: Group 1 relied on audio information only. Group 2 relied on audio and visual information of the speaker. Group 3 had audio, visual, and sentence repetition information. Group 4 were given the initial letter of the key word prior to listening to the sentence. This study found that all strategies were better than just listening to the speaker, with letter cueing being the most significant for increasing intelligibility. Lastly, Hunter concluded that therapy should include instructions to utilize strategies that are the most appropriate to the intelligibility level of the patient's speech. These findings are similar to a study completed by Buchelman and Yorkston in 1977, in which alphabet cueing, or letter cueing, was successful in reducing the speech rate and ultimately improving the intelligibility of speech for 2 patients with a CVA and a TBI. Using a feedback strategy to reduce rate and increase intelligibility was examined by Berry and Gosshorn in 1983, focusing on speakers with ataxic, spastic, and mixed dysarthria. The researchers found an oscilloscope using an oscilloscope to provide the speaker with visual information on the time it takes to complete a sentence while presenting words or underlining words slowly on a computer screen resulted in slowed speech that increased intelligibility. A study done by Yorkston, Hammond, and Trainer in 1990 on rate control via computer modeling at delayed and natural intervals was found to slow speech rate for speakers with ataxic and hypokinetic dysarthria and not decrease naturalness. Lastly, another study looked at the effects of using a metronome to slow speech rate in patients with spastic ataxic dysarthria. Pillen, McIntosh, and Thayer found in their 1998 study that pacing techniques increase intelligibility for severe patients and decrease intelligibility for less severe patients. Again, using the oscilloscope was also used effectively to increase the prosodic feature of loudness in the study done by Calgary, Murray in 1983 in speakers with ataxic, spastic, and mixed dysarthria. So overall, after reviewing the literature, we recommend that using the strategies to decrease speech rate and increase prosody would overall improve the intelligibility of speech for speakers with cerebral palsy and dysarthria. The next speech subsystem that we will be presenting on is phonation by Haley Curtis.
And respiration.
About 50% of children with cerebral palsy have communication disorders.
The article I researched investigated whether intensive speech therapy 3 times a week for 6 weeks using a speech subsystems approach to controlling breath support, phonation, and speech rate can increase the speech intelligibility of older children with dysarthria and cerebral palsy. Phonation and respiration were worked on together in therapy by practicing the beginning of exhalation in sustained vowels. Then the client and therapist moved on to coordination of exhalation in spoken language from word to phrase to sentence level. Children would speak words slowly while maintaining breath support and learning to breathe at appropriate times. Rate increased as the child learned breath support on a slower level. Overall, this study showed that intensive therapy was associated with increases in speech intelligibility. Both familiar and unfamiliar listeners saw increases of intelligibility in both single word and connected speech by at least 14% or more. When the older children assessed their own speech, they also saw improvements in their speech intelligibility. 14 of the 16 children rated that the therapy was definitely helpful, 2 rated it as partly helpful, but all of the children stated that they would definitely recommend it to a friend. The intervention should be tested further with younger children and older adults to investigate whether they too may benefit from intensive speech therapy.
Now we're going to talk about resonance. The article that I reviewed included evidence-based practice guidelines specifically for the management of velopharyngeal function in individuals with dysarthria secondary to stable, recovering, and degenerative diseases. This review included 33 studies that looked at varying diagnoses such as cerebral palsy, TBI, Parkinson's, and other disorders, and which treatment works best for those with pharyngeal impairment. Velopharyngeal impairment is a common result of many cerebral palsies, hyper and hypotonic, depending on the pathophysiology. This impairment means that the velopharyngeal mechanism does not open and close in a normal fashion, resulting in characteristics such as hypernasality, nasal air emission, and weak pressure of consonants. This imprecise resonance can be managed through prosthetic measures, surgical measures, and behavioral interventions such as different exercises. A speech pathologist plays a huge role in the assessment of velopharyngeal functioning and treatment to determine what will work best for someone with this impairment and who are appropriate candidates for alternative medical assistance. Specific to assessment of resonance, speech-language pathologists will need to examine the velopharyngeal mechanism. This can be accomplished by the use of instrumentation that may include video fluoroscopy, nasoendoscopy to observe palatal movement and lateral pharyngeal movement. After doing this, the SLP can determine if this person has appropriate velopharyngeal functioning or not. If this person does not have appropriate closure and cannot compensate for their impairment, a speech therapist may want to refer the patient for a palatal lift or surgical procedure. The article that I read stated that individuals with hypokinetic CP, which means decreased or slow movements, benefit most from prosthetic intervention because of the plasticity of their motor movements. The article also shared that surgical intervention was not recommended for individuals with CP until all other management options were ruled out. An SLP does not perform the prosthetic construction or surgical treatment, however, play a very important role in assessing, consulting, and establishing if someone is benefiting from a palatal lift or a specific procedure. The SLP is a member of a follow-up committee and makes sure that lifts fit appropriately for adequate communication function. An SLP must consider factors to determine if intervention of the velopharynx is best and would enhance other speech systems. Specifically to velopharyngeal treatment and intervention, an SLP can provide different treatments. One strategy that the article stated would be to use resistance treatment during speech. This task involves continuous positive airway pressure to exercise the soft palate during speech in order to strengthen the muscles for closure. Another strategy would be to use biofeedback techniques. Some people benefit from using a mirror or a nasal flow transducer during efforts to decrease airflow out of the nose and reduce hypernasality. Now we are going to talk about articulation.
Articulation. Articulation treatment is only advised when other aspects of speech production have been or are being assessed, because imprecise speech sounds are usually due to problems in controlling respiration, phonation, and the velopharynx, rather than solely the lips and tongue.
Oral motor treatments were used in a study by Clark in 2003 to remediate the weakness and hypotonicity seen in patients with spastic and flaccid dysarthria, and in patients with hypertonicity as seen in patients with spastic dysarthria. Two types of exercises were examined, focusing on active exercises focusing on strength training, and slow stretching exercises. The effect of strength training is unknown for improving articulation accuracy and intelligibility.
Therapy techniques that are based on non-speech movements of the velopharyngeal mechanism have not been endorsed by experts for several reasons, including speech and non-speech movements involve different underlying mechanisms, individuals only use a small amount of muscular force during speech, and methods do not provide the patient with information on the timing of accuracy articulatory gestures during speech.
Based on this, we recommend to differentiate what speech subsystems are contributing to the imprecise articulation, and to directly treat those subsystems prior to treating articulation by itself, in the event that the treatment of respiration, phonation, and velopharyngeal abilities will lend itself to improved articulation.
Clearly, the assessment and treatment of speech subsystems will not be the only role the SLP has regarding their involvement in individuals with cerebral palsy. Since our articles focus mainly on treatment strategies, we will briefly touch on the following roles in addition to treatment. One is the interdisciplinary team practice, including the consultation with and referral to other medical professionals. Along with this, we must counsel and train family and significant others about diagnosis and treatment. Lastly, using the WHO model to assess treatment outcomes and focus on treatment and increasing participation and activity level for our client.
Thank you for joining us in learning about our motor disturbances in cerebral palsy and the impact that this has on the role of the speech-language pathologist. Bye!